You count to 10 in your head, and
The
then
broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this webinar entitled Fighting the Growing Threat of Antimicrobial Resistance. I'm delighted you could all join us today, and as part of Antibiotic Awareness Week and obviously the forthcoming European Antibiotic Awareness Day on Friday. We're very delighted to have the support of ALEA for this webinar. I'm going to introduce today's panellists. First of all, we have Dr. Till Bachmann. Till is a Region in Personalised Medicine, Infectious Diseases in the Division of Pathway Medicine at the University of Edinburgh. His scientific interest focuses on rapid molecular diagnostics of infectious diseases and antibiotic resistance targeted stratified medicines. Till has published extensively, is a named inventor on various patent applications and has led a number of large interdisciplinary diagnostics projects, including Tech Media Chronic Wound Care and Biosensing Platform Programme. So he's also founding member of the European Diagnostics Cluster Alliance, and he sits on the Science Advisory Board of the Biomedical Diagnostics Institute and the steering group of the Biosensing Group of Electronics, Sensors, Photonics, KTM. We also have Dr. Anne van der Bro, and she's an Associate Professor, Department of Primary Care Health Sciences, Director of NIHR Diagnostic Evidence Cooperative in Oxford. Anne's research focuses on diagnostic tests. In recent years, Anne has worked mainly on the diagnosis of serious infections in children, including a large-scale study of the diagnosis and how parents and doctors view the diagnostic process when a child is admitted to hospital with a serious infection. These results of these studies have been used in several guidelines, including one on feverish children by NICE. More generally, she has collaborated with colleagues in other studies on diagnostics tests, such as clinical features in patients with chest pain, ultrasound for patients with shoulder problems, exercise testing to identify coronary disease, and she's currently director of the NIHR Diagnostics Evidence Cooperative Oxford, which aims to facilitate diagnostic innovations in the NHS. The cooperative offers training advice for anyone who is developing a new diagnostic test for primary care. And finally, we've got Dr. Jane Ellis, who is Medical Director of Western Europe and Nordics for ALEA. ALEA focuses on market development for point of care testing. She has an active role in global antimicrobial resistance. Dr. Ellis has earned a PhD in biochemistry from the University of Wales College of Cardiff and completed her postdoctoral research at the University of Cincinnati. Dr. Ellis has co-authored 40 peer-reviewed publications and presents regularly at the National Public Health and Scientific Meetings. As part of ALEA, ALEA are renowned as the #1 global provider of rapid point-of-care tests, with solutions available in over 100 countries. ALEA believes that knowing known matters by delivering reliable and actionable information through rapid diagnostic tests, resulting in better clinical and economic healthcare outcomes globally. The rapid tests are used near to the patient, such as GP practices, pharmacies, and also in emergency departments, ICU, and hospital laboratories. I'd like to welcome all our panellists today. Without any further ado, I'm going to introduce the first of these panellists, which will be Dr. Till Bachmann, who's going to set the scene around diagnostics, and he will speak for around 10 to 15 minutes as part of this presentation. Over to you, Till.
Okay. Right. Thank you very much, Scott. And do you see my screen, or?
We do.
How do I move the slides?
You should just use your right keyboard key, or click on the slide itself.
Sorry, it's not moving. Okay, slow. Oops. Can you go back, please? Can you go to slide 1? All right, that's fine. Okay, so yeah, thank you very much, Scott. Yeah, it's a pleasure to talk at this webinar. And just very briefly, thank you for the introduction and the background. Just briefly on my background of my research group. So we are really sitting at the interface of understanding antimicrobial resistance and working on the research of medical microbiology and biomarkers. And we do research on biochip technology, so detection platform, diagnostic technologies, We merge those two and we arrive at molecular in vitro diagnostics, which, as we hope, will enable targeted and effective antimicrobial therapy. Going to the next slide. I was asked to set the scene, and as such, I thought I'd show these slides from the O'Neill Commission, the independent review on AMR. And we're all here because we understand that AMR is a global challenge. And as the report has modeled, there will be, if we don't tackle AMR, by 2050, it's postulated that we have an excess of 10 million extra deaths, which can be attributed to AMR every year. Now, the situation is obviously dramatic, and if we compare this to other indications, other diseases and causes of deaths, then AMR will exceed cancer as we know it today as the cause of death. So this puts things in context. From its severity, but also from a global perspective. If you look on the right side of the slide, the numbers of deaths which can be attributed to AMR would be mainly located in Asia and in Africa, but also in Europe, North America, and South America and Oceania. So it's a dramatic issue, and we're here to address this. Obviously, there is a correlation between the antibiotic use and the occurrence and likelihood of resistance. And this slide, again, is borrowed from the review on antimicrobial resistance, which shows the outpatient use of penicillin in the year 2000 versus the penicillin non-susceptible Streptococcus pneumoniae, which are observed in the various countries. And what you can see is the more of the antibiotic is used, the higher is the incidence of antibiotic resistance in this case. So the idea behind such observations is that if antibiotic use can be reduced, the resistance will be also less. So diagnostics should be a tool to help tackling that issue. Just a few data on the global antibiotic resistance situation, and this one here is from a recent report from CDIP from 2015, looking at the global MRSA trends. And what you see here is, if you are looking for the UK, we have a fortunate situation that from 2006, the MRSA rates were falling. And now it can be debated what the reason for this is, but certainly antimicrobial stewardship programs and hygiene programs certainly have contributed to that. Other countries are, in other countries the situation is less fortunate. So in the US, for example, or specifically in India, we have an increase of the MRSA rates which are observed in those countries. Other countries like Denmark have very low rates, and obviously an interest of the research community is to understand the reasons for those various rates. Now, if you look at the different pathogen, so moving from the gram-positives to the gram-negatives, famous example is the New Delhi metallolactamase, NDM1. We have obviously more variants since the discovery of NDM1. And what this graph here shows, this figure is showing that it originated in around 2006 from the Indian subcontinent, and today we find it across the world in various locations. Now, what this shows is that antibiotic resistance is a global issue, and antibiotic resistance genes and the associated pathogens are spreading. And so we need to consider the issue and tackling the issue from a global perspective. Mentioning the global perspective, I wanted to show that there are a number of global policy responses to antimicrobial resistance, which are quite intensely pursued. The most recent one was the high-level meeting on antimicrobial resistance of the General Assembly of the United Nations, which happened on the 21st of September. And it was mentioned in the introduction, the ECDC has a number of activities, including the upcoming Antibiotic Awareness Day on the 18th of November every year, and so also this year. So on Friday is European Antibiotic Awareness Day. Now, in the UK, in 2014, we saw the launch of the O'Neill Commission, the independent review on antimicrobial resistance. This brought out a number of reports addressing and describing the issue and how to overcome the problem of antimicrobial resistance. And in the final report published earlier this year, 10 major points to tackle antimicrobial resistance were described, including, from our perspective, importantly, rapid diagnostics. Beyond rapid diagnostics, the report proposes to focus on public awareness, sanitation and hygiene, antibiotics in the agriculture, vaccines and alternative of antimicrobial treatment, surveillance, human capital, novel drugs, and international coalition for action. Now, importantly, and we may come back to this, there's also discussion on a global innovation fund to stimulate antibiotic drug development and the use and implementation of rapid diagnostics. Now, very briefly, what is the unmet need in clinical microbiology with regards to antibiotic use and rapid diagnostics? Summarized in this slide here. So if a patient comes to a healthcare setting with an indication which requires therapy, what we do is that a sample is taken and analyzed and summarized here. So it can be that you, in case of a blood sample, we cultivate the bacteria in the blood culture to identify and if there is a pathogen present in the sample, and after that was positive, you may take a sample and take this onto a plate, again unculture it and expose it to antibiotics and see if there is susceptibility or drug resistance against the antibiotics tested. The issue is that you have to start the intervention when the patient is presenting, and you don't have the time to wait until the information is provided. So you may choose an antibiotic which is inappropriate or a patient management intervention which is not suitable for the actual situation. So what we would like to have is we would like to have rapid diagnostic tests to support therapy decision and the choice of the antibiotic, but also to support patient management decision. And these rapid tests should be done really at the onset when the patient is presenting, or when an intervention is required. Now, there are obviously numerous activities across the world to develop and implement antibiotic rapid diagnostics to tackle antimicrobial resistance. However, there is no one solution for it available so far, and this led to the initiation of stimulation prices and market intervention prices from various governments. And I listed a few here on this page. In the EU, we had the EU reducing the misuse of antibiotics price. It ran out in August. I've been fortunate enough to be on the panel, so a winner has been selected, and I'm pretty sure it will be announced quite shortly. The longitude price, again, I'm fortunate to advise on the longitude price, is a price for a point-of-care test which can be applied globally. I will come back to this in a second. It's a 10 million price. And in the US, there's the counterpart for this. There's a $20 million price for someone who comes up with a rapid point-of-care diagnostic test to tackle the need for antimicrobial resistance tackling. Now, these are obviously fairly large activities, and they are addressed by various groups. There are smaller, earlier stage antimicrobial resistance diagnostics prices and initiatives, one of which is the UK Discovery Award, which can be understood as an earlier stage within the process towards applying and winning the longitude price. Again, I had the opportunity to judge on this, and we see a few winners which will be announced next week, actually, at the anniversary of the Longitude Prize on the 21st of November. And in Edinburgh, we launched the AMR DXC, the Antimicrobial Resistance Diagnostics Challenge competition, which addresses the interaction between research in developing and in developed countries. We had an Edinburgh, UK-India school on AMR diagnostics in 2015, and we will mirror that with a school in Bangalore, tackling the diagnostic test development, but also the implementation and social science aspects indicating or addressing behavioral change requirements. And we do for the rest of the world, if you want, not India, but other low and medium income countries, we do another school in Edinburgh early next year. Now, if you look at the requirements for successful tests, I wanted to show you the Longitude Prize examples. We have the definition of the criteria to win the prize, and which are an interesting and good summary of the requirements. So the test has to be needed in the countries, obviously, and so they have to, it has to address a critical issue where AMR plays a role. It has to be accurate, it has to be affordable, it has to be easy to use, scalable, it has to be safe, connected, and you have to have a prototype. It has to be rapid, and this is, from a Longitude Prize perspective, the only really defined quantitative criterion. It has to be faster than 30 minutes from sample collection to the result. And if you look at the criteria here, the major overarching one, it says you must develop a point-of-care diagnostic test that can rule out antibiotic use or help identify an effective antibiotic to treat a patient. This is a very challenging requirement because it implies that one is able to identify and name an antibiotic which can be used after the test result is there. Now in the next slides we will see that this is actually a challenge, or where the challenge is for this. So if you think about the diagnostic and what is actually measuring, we can look at these stages which are depicted here, which are broadly taken from, again, the image at least is taken from the AMR review. So if you start from the bottom here, so the initial discrimination is on the choice for an antibiotic, do we have a bacterial or a viral infection? Now, a lot has been published and worked on identifying biomarkers for that perspective or for that question, and yeah, it can be, well, it should be discussed on how useful those biomarkers are in terms of the detection. Now, on the next stage on complexity of the assay, one would identify the bacterial type. Knowing the bacterial type obviously helps choosing the intervention. However, what we really would like to know is the resistance, which would tell us which antibiotics you should not use, or ideally, and the holy grail would be to identify and know the susceptibility, telling you which antibiotic you can use so it works against the pathogen which is causing the disease for the respective patient. Now, if you look at the very common format for such diagnostics tests, then this is depicted here. What we very often have is that we have these sample to answer diagnostic test formats, which start with a sample which is taken from the patient, transferred into a disposable cartridge, and then placed into a reusable reader, and then after the processing you have the result. Now this is by purpose shown in a very generic scale here. So that we as test developers, we tend to focus on the disposable cartridge and the technology which is implemented in those cartridges, and then how this technology is driven by the reusable reader. Now the user really considers this as basically what we have a lab and a matchbox, a lab on a chip, a lab in a very simple, easy thing, which the user is not really interested in the mechanism, but that it is easy and cost effective. So we consider this really as a disposable piece of equipment or a piece of a cartridge which is then used in a reusable reader. Now, from our perspective, I just want to mention one activity which we have is the chronic wound care program, which laid the foundation of a test which we are working on here for the identification of MRSA from clinical specimen without PCR, so it's without amplification. And the idea is that one takes a sample from a chronic wound, for example, such a diabetic foot ulcer here, which may be infected, and analyze it with a simple, portable, point-of-care compatible device. Now, the technology we're using for this is called electrochemical impedance spectroscopy. In short, that's EIS. The good thing with this is it's label-free, it's a surface-sensitive technology, and it can be, if you functionalize the surface, it can be very specific. So what we do is we measure addition of targets to a functionalized surface. This is an electrode surface, which then indicates by an increasing signal that something has bound to its surface. And so because this is an electrochemical process and it is label-free, it is very suitable for very simple assays. And I give you two examples. One is amplification-free detection of NDM1 plasmids or NDM1 bearing plasmids. So what we do is we extract plasmids from bacteria, process them and hybridize them to the electrode surfaces and then monitor the increasing signal. And the real data are shown down here, showing NDM1 plasmids hybridizing in a short time scale and being detected in a short time scale on these sensors. Another example I wanted to share is the amplification-free MRSA genomic DNA detection, shown here. Depending on the number of cells or cell equivalents, we see an increasing signal of the sensor resulting from the increasing hybridization of material to the sensor surface. So both these examples which I showed are examples from a wider application bandwidth which we have with this platform. So it's one detection technology and we can apply it to many targets in the nucleic acid space. I mentioned the MRSA and NDM1, but as we have upcoming targets like last year, the MCR1 plasmid encoded colistin resistance, we are able to detect that as well, but other markers are also possible. Because it's a platform and we're interested in infection and we need to clarify if there is an infection actually happening, infection markers are important, so we demonstrated that for TREM1, for example, as an infection marker. Or for small molecules like HSL to detect, so homoserine lactone to detect quorum sensing. And in the interest of time, I think that's me talking about our work, and I put my contact details here because I guess the slides are shared, so if you want to get in contact, please do so. Thank you very much.
Thank you very much, Dr. Bartman. Yes, the slides will be shared. They will be available for people post today, and they'll be disseminated to our registrants today and to a wider audience. Without any further ado, I would like to welcome our next speaker, Dr. Anne van den Brul, who will talk about some of her work and research. Anne?
Thank you. So I'm going to talk about the studies that we've done mainly on serious infection in children, and basically we've focused on clinical features, but I'm also going to talk a little bit on the value of biomarkers or laboratory tests. So moving on, how can I go to the next slide? Yeah, okay, here it is. Thank you. So primary care, obviously, as everyone knows, we deal with a lot of acute infections and coughs, colds, earaches. They're very common symptoms. And although they're very common and most of these infections are dealt with in primary care itself, the pressure on secondary care is increasing. A lot of patients show up at the pediatric ED with febrile illness, and the unplanned pediatric hospital admissions have increased by 20% over the last decade, and in fact almost 1 in 5 of the children who are admitted to hospital for an acute problem, they are admitted for upper respiratory tract infections, which seems to be unnecessary, but we think that a lot of this is driven by the diagnostic uncertainty. At the point of presentation, it is often difficult to distinguish whether the child suffers from a serious infection or whether this is a more common and self-limiting infection, and that leads to care escalation. So when you have a child that presents to primary care with an acute illness, and this could be a child from the age of 1 month up until 16 years of age, only 1 in 300 will have a serious infection, and that includes pneumonia, sepsis, meningitis, pyelonephritis. 4 out of 5 will have pneumonia, so by far they are the most common serious infection, and the other serious infections such as sepsis and meningitis have become extremely rare over the past decades thanks to successful vaccination programs. So we are really looking for the needle in the haystack if we are assessing children who are acutely ill and want to make sure that they don't have a serious infection. Oops. Could you go back, please? Yeah, thank you. So the clinical tools that primary care clinicians use most are just clinical examination, observation, and history. And a minority of children will get laboratory tests or radiology. But a substantial proportion will get what we would call watchful waiting. So you would either instruct parents to come back at a specified time or when specific symptoms occur, or you ask patients to reconsult the next day and review the situation. But a lot of it is clinical, as I said, and that's why we decided to look into the diagnostic value of clinical features a bit more, because it was identified as an evidence gap 15 years ago by several guideline developers across Europe, and there was just not enough evidence from primary care itself about what are the clinical features that are useful for diagnosing serious infections in children. So what we've done over the past decade or so is we've done several studies in large groups of children. They were all prospective diagnostic studies or cluster randomized controlled trial, where we tried to identify the best clinical features to either rule in or rule out serious infections, and what the added value would be if we would add a CRP point of care test over and above the clinical assessment of the child. So this is just a slide to illustrate the fact that it is necessary to do diagnostic studies in the setting in which you are planning to use the test. This is a slide that shows how the risk of a serious infection changes according to a patient's temperature, and I can see that the symbols have gone slightly wrong, but if you look at the left-hand slide, that's where primary care is. So the pre-test probability of a serious infection is very low. And if the child has fever of 40 degrees or more, then there's a substantial increase in the risk of a serious infection. That's the red square. But as you move along the axis to the right, you increasingly see higher risks of serious infection, because those are those settings that are more hospital-based, like emergency departments or hospital admission wards, where the risk of serious infection is much higher because patients have been selected based on their illness and presentation. So, for example, the green triangle, that's a setting which could be an ED, for example, where the risk of a serious infection is slightly higher than in primary care, and a temperature of 38 degrees or more also increases the likelihood of a serious infection. But as you move along more to the right, those changes become smaller and smaller, and it shows that fever is probably a very good red flag in primary care, but not so much in more selected populations that are admitted to hospital. It sort of loses its diagnostic value along the referral pathway. And this is another slide from systematic review that we've done, and I wanted to show you this because it illustrates the asymmetry of clinical features. So a lot of clinical features, such as cyanosis or poor peripheral circulation on the top of the graph, they are very good at ruling in. So they are a good red flag. Let me just briefly discuss this slide with you. So if you look at the blue circles, they are the baseline risk of a serious infection. So before doing a test, this is the risk of a serious infection in that child in that particular study. Now when you do the test, and for example poor peripheral circulation, when you find that in fact the child has poor peripheral circulation, then the risk of the serious infection increases to the right to the red circles. And when the child does not have poor peripheral circulation, so when it is reassuring, then the risk of serious infections decreases to the left to the green circles. So you can see from this graph that there is a big difference between the increase when there is actually poor peripheral circulation versus the decrease when there's no poor peripheral circulation. So these features are better at alerting someone there might be something wrong. They're good at increasing the risk, but they don't do very much in decreasing the risk. So they're not useful to rule out. They don't reassure you when they are normal. And we can see that across the board for all different clinical features, that they're such as meningeal irritation, petechial rash. They're all very good at increasing the risk of a serious infection, but not so much at decreasing. So in effect, when a GP assesses a child and they look for these red flags, when you don't find meningeal irritation, you can't really say that you've excluded the possibility of a meningitis because the risk sort of stays unchanged. We also looked at very well-known observation scales such as the Yale observation scale, and found it was not very useful in primary care especially, but actually not in selected populations. So we advised against using that in primary practice, in routine clinical practice. And then I just briefly wanted to mention two clinical features that we found were very useful, especially in primary care, and probably because primary care has a unique position that it has a long-term relationship with its patients and families, and so they can take other sort of information into account, and that is parental concern that the illness is different from previous illnesses, and the gut feeling or clinician instinct that something's wrong. Both were found to be the most powerful red flags from any clinical feature that we assessed for diagnosing serious infections in children. And we know from research that we've done in this area is that gut feeling, for example, is generated by other information than the pure clinical examination. So it can also be influenced by differences in behavior from the parents. So if they phone up late at night, and they normally never do, and just take an appointment and wait for the appointment, but that day they phoned up in the evening and they were really worried, that's sort of the information that makes GPs have a gut feeling that something might be wrong, and it actually is a very powerful red flag for serious infections in children. So it increases your chance from less than 1% baseline risk of a serious infection up to 20% when a GP has a gut feeling that something might be wrong. And then we constructed a prediction rule because all the clinical features individually, as I said, they can increase your risk of a serious infection, but they're not suitable for ruling out serious infections. And in order to be able to rule out serious infection, because that's one of the main goals in primary care, is to be able to say, well, this is not a serious infection. We constructed this prediction rule that was, it was derived in 2007, and then last year we validated it in an independent new population of children, and it was found to be 100% sensitive, which means that it didn't miss any serious infection at all. And we looked at 12,000 children in total, so we are pretty confident that it is a precise estimate. So when the GP does not have a gut feeling, when the child is not dyspneic, and when it doesn't have a fever of 40 degrees or more, then it is safe to exclude a serious infection in primary care. Because we tested it in secondary care as well, and it didn't. It was not that sensitive in secondary care. We need different prediction rules for each setting. And then moving on from clinical features to laboratory tests, so we looked at all available evidence for laboratory tests for diagnosing serious infections in children, and we found that procalcitonin and C-reactive protein, or CRP, are the best inflammatory markers that we have so far for diagnosing serious infections in children. And in fact, white blood cell count, which is often used for serious infections in children, we found it has very limited diagnostic value for that purpose. So we advised against using that for serious infections in children. So we took these CRP, because the CRP, there are several point-of-care tests available that are useful for primary care, because it produces a result that's fast enough to be incorporated into the daily routine of a primary care practice, whereas procalcitonin at the moment, the available point-of-care devices aren't producing results quickly enough. So we used CRP in a cluster randomized control trial, and we came up with the following stepwise diagnostic process as a result of that. So these are 300 acutely ill children presenting to primary care. And the first step is to use the clinical prediction rule that we constructed. And if the child doesn't have, GP doesn't have gut feeling, the child isn't dyspneic, and doesn't have a temperature of 40 degrees or more, then you can exclude a serious infection, and that happens in 240 of those 300 children. So quite a large proportion can be excluded based on clinical grounds alone. Subsequently, in the group that remains, so the 60 children that remained after the clinical assessment, if you would do a CRP test in those 60 children, and you would use a very low cutoff of 5 milligrams per litre, which is much lower than what we found in hospital settings. But again, in primary care, we just need to have our own diagnostic thresholds, because patients present quite early in the illness trajectory and might have milder forms of the disease as well. So thresholds probably matter a lot when you do research on biomarkers. So second step in this process, CRP, when it is not above 5 milligrams per litre, again, you can exclude a serious infection in another 24 children, which leaves 36 children in whom you would have to do either additional testing or refer the child to hospital for hospital-based assessment. And ultimately, that is to identify the one child at the bottom right, the one child with a serious infection that was presented to primary care initially. So are we going to get it right when we use this? And I think we need to be a bit cautious here, because although we have done studies on 12,000 children in total, there will always be this one child that didn't get into the studies. I mean, the very dramatic and very fast evolving meningococcal sepsis that ends in the child dying, we didn't have a single case of that in our studies. So we just need to be a bit careful and always apply safety net when we use these results in clinical practice. So we need to be able to instruct parents when to come back and offer the opportunity to make an appointment when necessary, when the situation changes. So I think that's quite an important message, that despite all our efforts, we still will need that safety net to avoid fatal consequences. So in conclusion, in primary care, serious infections are very rare, and they present among a huge amount of very common acute illness, which is very difficult to distinguish between one serious infection versus the 299 non-serious infections that also present in a similar way. We know now that clinical features are limited in their value and they are useful as red flags, but should never be used to exclude a serious infection in isolation, although the combination can be used as we've shown in our clinical prediction rule. And then laboratory tests can be used to further exclude serious infections in the proportion of children that are at higher risk based on the clinical assessment. That's all from me. Thank you very much.
Thank you very much, Anne, and thank you for that presentation. Just to remind our registrants today that you can raise your hand if you do have a question at any point with the option on the control panel allows you to raise your hand and have a question. Our final speaker we're delighted to have is Dr. Jane Ellis, Medical Director Western Europe and Nordics at LIA. Over to you, Jane.
Thank you very much, Scott. So I'll be talking about CRP testing in the point of care testing in primary care and acute care. It follows on quite nicely from what Anna's just been describing in children. Obviously, I'm going to focus on the use in adults and the experience in the UK. If I can move the slide. So antimicrobial stewardship and diagnostics, as I'm sure most of us are aware, most antibiotic prescribing occurs in primary care, and it's well monitored now by Public Health England. The latest figure showing 78% is present there. And over half of those antibiotics prescribed in primary care are for respiratory tract infections. There's strong evidence that primary care CRP testing for respiratory tract infection in adults reduces antibiotic prescribing and enables patient education and the consultation discussion. And this is especially relevant when there's a high degree of diagnostic uncertainty. For patients who are very worried or demanding antibiotics, which we hear can commonly occur in primary care, and also importantly to differentiate the seriously ill from the non-seriously ill. I think I might have gone, could you just go back one slide, please? Thank you. Using point of care CRP testing was recommended in December 2014 by NICE in Clinical Guideline 191. And this guideline recommends that GPs should consider carrying out a point of care CRP test for people presenting in primary care with symptoms of lower respiratory tract infection. And that guideline sets out a nice algorithm that really clearly showed, I think, for the first time in a NICE guideline, how to use CRP in primary care for these types of infections. So a very low level being in adults 20 milligrams per litre. The recommendation is do not use antibiotics in that group. In the group that have very high levels, over 100 milligrams per litre, to offer antibiotic therapy. And for the group in the middle, NICE recommended to consider a delayed antibiotic prescription. There's lots of evidence showing how you can use point-of-care CRP testing to reduce antibiotic prescribing, and that the fact that it can rule out unnecessary antibiotic prescriptions. This data was really developed in Europe from large randomized controlled trials in primary care, studies run in the Nordics, in the Netherlands, and some centres in the UK showed that you could actually reduce antibiotic prescribing by up to 41%. so quite significantly in this group of patients presenting with lower respiratory tract infection symptoms. CRP test can be done very simply and quickly, and mentioned, and it takes just 4 minutes. And as I said, you can use this very simple rule-out algorithm. Using CRP point-of-care testing as well is in line with key NICE guidance, as well as in the pneumonia guideline. It's mentioned and recommended in the Antimicrobial Stewardship Guideline, NG15. It also supports the ambitions, as Dr. Bachmann mentioned earlier, set out in the final AMR review report, where Lord Jim O'Neill mentioned specifically that he feels that governments of the richest countries should mandate now that by 2020 all antibiotic prescriptions need to be informed by up-to-date surveillance information and a rapid diagnostic test whenever one exists. So a strong push, as we've seen and heard, that really antibiotic prescriptions, if it's uncertain, if they're needed, should be backed up by some better evidence. The CRP test is very easy to do. It's a tiny blood sample. It takes 1.5 microliters, and the sampling tube's integrated into the test cartridge, so you can just use a capillary action to get the tiny little pool of blood into the sample cartridge, and it then goes straight into the analyzer, and a quantitative result's displayed on the screen in just 4 minutes. The actual device itself, the analyzer, can be attached to a small printer which can print out a record to attach to the patient's record or stick in on the sticky label, or it could be connected to the primary care system, or even it's been used in pharmacies and connected directly to their electronic systems. And as it's been used more and more in UK primary care, we've had good feedback saying that they found it actually quite simple and easy to use. And this type of technology is also used in NHS health checks, where on the same system you can run lipids and also HbA1c. In terms of using the test, obviously a lot of the data previously published has been completed in studies that were not conducted in the UK. So it's been important that pilots have been run to show what the benefits are and show that we can achieve similar results from UK pilots. ELIA developed and launched the test for CRP on the Affinium platform in 2005. So the system's very robust, and it's been used on millions and millions of patients over that time. And following the NICE introduction of the NICE guideline, a number of pilots were started and have now been completed, and reports are coming out, papers being drafted, and also posters being presented in England, Scotland and Wales, in a GP setting and also in the acute care setting. And what we are seeing from the studies is some consistency with data from the randomized controlled trials that were run previously, and also from data feedback from European users of the system. And a summary of the data is here from 8 pilot studies where they altogether tested 1,653 patients. What they see consistently is most of the patients who present with these types of respiratory tract or acute cough symptoms have very low CRP. So on average here, 73% with a CRP of less than 20, 5% with the high CRP, and about 22% of those with the CRP in the 20 to 100 region. This is data from a study, a pilot run in Scotland by the Scottish Antimicrobial Prescribing Group, where they looked at 231 patients in 10 GP practices. And this shows you their data, where of those patients, the majority you can see present with symptoms and have a very low CRP level, which helps the clinician to be able to rule out the need for an antibiotic in that patient. And those presenting with very high levels was much smaller. But actually some feedback on that was that it was interesting, some of those patients don't necessarily have very marked symptomology, but to see such a high CRP meant that some of those patients were actually sent in for a hospital referral for further follow-up. Antibiotic prescribing reduction, the mean from those 8 studies is 33%. So it kind of is confirmed by all of the sites that we've worked with that they are seeing the reduction in antibiotic prescribing that they were hoping to see. And they typically measure by comparing the data of the CRP implementation period with that exact period the year before. This is data from Attenborough practice, which is in Bushey near Watford, where they implemented CRP testing in the winter 2015-2016. The study was done with 67 patients, and what they showed was a marked reduction in antibiotic prescribing, both actually with the reduction of antibiotics, but also the reattendance of those patients that were not given an antibiotic was markedly reduced as well by over 50%. This was an advanced nurse practitioner-led clinic looking at minor illness in patients presenting, and the lead investigator here, the feedback was that patients were reassured when they saw the CRP results and more likely not to be so worried if their symptoms persisted for the next 2 to 3 days. In Bradford Royal Infirmary, they ran a study in the acute care unit. The issue here was that lots of patients were presenting with respiratory tract infection symptoms, but obviously they weren't considered to be so seriously ill. And they wanted to see if they implemented the NICE guideline for primary care, it would help them quickly rule out the need for antibiotic in these patients, and also understand the seriousness of the infection that they were, or the symptoms that they were presenting with. So in this acute care setting, they examined 93 patients, and antibiotic prescribing was compared with the month prior to CRP intervention. And they found a marked reduction in antibiotic prescribing, dropping from 70% to 20% in the period investigated. The Scottish Antimicrobial Prescribing Group, as I mentioned, ran a study last winter in 10 practices, and this is just some of the summary of the data that they have produced, and it's available on their website. It evaluated the feasibility to support clinical decision making in 246 patients and was used by 15 GPs. Over 90% of respondents felt that the CRP point of care test provided reassurance when not prescribing an antibiotic, and almost 2/3 of GPs thought that point of care CRP was a useful additional tool to support clinical practice. 40% of GPs subjectively thought that the CRP point of care test reduced levels of patient reattendance. And the patient experience of the test appeared to be positive, and the majority of respondents would like to see the testing used routinely. These are some anecdotal feedback that are published in a publication by Hughes from a study in Anglesey where they implemented CRP point of care testing, and feedback from the GPs that they were able to do more focused prescribing, helped them in decision making. It was a big influence in how much antibiotics they were prescribing, and they felt that they were able to reduce costs, obviously specifically of antibiotics. It was helpful when patients were keen for antibiotics, but their CRP was normal, to alleviate the pressure that being felt by the patient and to reassure them. And it was saving time, gives instant results, and antibiotics given out less often. So in summary, CRP point of care testing has been used now in a number of pilots in the UK, and the data is looking very consistent with what we've seen in the large randomized controlled trials. So it can offer an important component of antimicrobial stewardship programs. The test has been supporting antimicrobial stewardship programs in a number of other European countries for many years, such as the Netherlands and across Scandinavia. And now it's increasingly being used across the UK with numerous pilots demonstrating effectiveness. So increasing uptake of CRP point of care testing can help to reduce levels of inappropriate antibiotic prescribing, reduce patient reattendance, lead to cost savings, and strengthen clinical decision making and reassure patients. And thank you very much.
Thank you very much, Dr. Ellis, for that presentation. I've got a question to the panel. Individually, you can answer this, please. What do you feel are the biggest challenges the diagnosis area or diagnostics is facing going forward? Is there an issue of adoption by clinicians of diagnostics? And is there an issue or is there any barriers that you feel you're working on at the moment to overcome in the take-up and use of diagnostics going forward? Till, have you got any theories on that, any of the challenges that you've come across recently? He's unmuted himself. Bill, are you there?
Here I am. Can you hear me?
Yeah, did you catch that question?
Yes, I heard the question. Yeah, I was expecting that you list a number of issues which are there. So there are obviously a number of them. One of them is adoption, but maybe I let my colleagues answer the adoption question. From our perspective, the major issues are that you need. So antimicrobial resistance is a moving target. So you're facing evolution and evolution of antimicrobial resistance, evolution of the pathogens. So if you identify a way to diagnose a specific scenario, you may be in a position that you cannot use this diagnostics entirely later in time. So we had this situation with MRSA, where we were used to detect MAC-A as a target, as a gene conferring MRSA for penicillin binding protein 2A, and all of a sudden MAC-C was occurring. Now MAC-C has been introduced as an alternative target or additional target in various molecular tests. The clinical relevance of MAC-C is debated, but still, for the acceptance of a test, the addition of targets or the additional occurrence of targets in the field is an issue. So evolution of the target is a problem. The other one is the rapidness of a test and the ease of use, and for a technical developer or a developer of the diagnostic technologies, that's a particular challenge. If you think about the various biomarkers which may be included in the holistic approach you want to take, from the host response as it has been described for the CRP test, or the biomarker tests in general, but on top of that you may want to include pathogen information for the information to select an antibiotic. I stop here in answering that question.
Jane, take-up adoption of diagnostics, barriers that you think there exist, funding for instance, how we increase rapidness, as Till mentioned. Have you got any thoughts on that?
Yeah, sure. I mean, when primary care first started using CRP and the pilot started, I think some of the concerns were around, can I actually do this in the consultation time, etc. And certainly we found lots of sites do make that work. Often they have nurses that run the test, or it's run in a particular part of the surgery. So we found that actually including it in the consultation and managing the patients with it isn't a barrier. The larger one, I think, is the issue of balancing priorities, the commissioners balancing different local health priorities, and where antimicrobial stewardship fits amongst those different priorities. So I would say there's lots of interest in primary care and commissioners in utilising these tools, and obviously they want to have their antimicrobial strategies in place, antimicrobial resistance strategies. But I think that, you know, perhaps more of a national approach to funding would definitely help, but funding can be an issue for some areas, yeah. Yeah.
Right, well, I would like to say thank you to all the panel, to Dr. Till Bachman, to Dr. Jane Ellis, and to Dr. Anne van der Bro. Thank you all for those who registered, and I hope you enjoyed today's webinar. It will be the first in the series we'll be doing. as part of our support for antimicrobial resistance going forward, and the slides and the webinar will be available probably within the next 48 hours, hopefully before Friday's Antibiotic Awareness Day. We would like everybody to get out there and support Antibiotic Awareness Day as much as possible, and if you've not already pledged, pledge to be an Antibiotic Guardian. And thank you very much for joining us, and we look forward to maybe coming and meeting you in the future. Thank you very much. Bye.